So today's lecture is on religion, death, and dying. We'll start with religion, and one important thing to think about when we're talking about religion is distinguishing between spirituality and religion. So spirituality has to do with a search for meaning. This is linked to, in terms of older adults, hopefulness among nursing home residents, and is often the most addressed topic in home hospice visits. It's often helpful with kind of coping for long-term terminal illness and helps patients overcome fear of death. In contrast, religion has to do with kind of the structure and organization for the spiritual experience. So this graph is showing the percentage of adults who are active members of a church, and you can see that it increases across the lifespan, with women being consistently higher than men. And religiosity is linked to longevity and health status, higher self-esteem, and improved well-being. And one of the reasons we think it's helpful is that it provides a support system in terms of beliefs, but also religious leaders and social supports. So it helps older adults find meaning, especially if they're dealing with a serious loss, and connects them across kind of cultural traditions to their family. And these are just results from one study that I thought was interesting. This is looking at the benefits of religion. And this study looked at Mexican Americans over 70 and found that those who had the highest levels of church attendance, so the highest levels of religiosity, which are the white bars, were less afraid of falling 2 years later. We know that kind of a history of falls and physical problems can often precede a lot of health problems in older adults. And so this fact that religion helps kind of prevent this fear of falling is really interesting. We also know that depression is associated with less religion, or less religion is associated with more depression. This is findings from a study that compared patients who were diagnosed with major depression to those who were not. These are over 58. And within those participants who were depressed, they found that those who had less severe depression had more worship attendance and less religiousness. And this is only partially explained by social support as kind of a buffer for stress. And so this suggests that religion kind of relates to depression diagnoses and severity in multiple ways, but generally it seems to help prevent or decrease depression. Okay. In terms of death, we have to start by a definition, which is, of course, the end of life. It's built into every life form, so every life form has death in some capacity. In terms of a medical definition, these are the criteria here: a lack of response to even painful stimuli, the absence of spontaneous muscle movement and breathing, in particular, no spontaneous breathing after the respirator is turned off for 3 minutes. No observable reflex, including brain and spinal reflexes, so this includes pupil responses to bright light and swallowing, and also the absence of brain activity, which would look like a flat EEG. So the general concept of death is that it's universal and inevitable, it's irreversible, and it's the cessation of all physiological functions. And biological death marks the end of existence. When we're talking about humans, we of course have all these medical interventions, and so there's a lot of end-of-life decision-making. And one of the ways that these decisions are made is through medical directives, which basically explain how much care an individual wants in a given situation. So do not resuscitate order, or DNR, as it directs physicians to not use CPR or electric shock or open chest massage when the breathing or heartbeat has stopped. So essentially saying don't use excessive measures to resuscitate. This is most likely in patients over 75. Many who have dementia or chronic illnesses create these orders. Much rarer is the decision to forego hospitalization or a do not hospitalize order, but some patients do also order that. But when we're thinking about these kinds of decisions, end-of-life care should be compassionate and should take into account what the patients want, but also what their families need. And so we try to get the families to use their best judgment for what the patient would want. Often, unfortunately, what happens is families avoid discussing the patient's wishes until it's too late, and then they have to kind of guess what the patient would want. So it's really important to have open discussions with the patient, if possible, along with the family and the physician. So historically, people have died at home where they're most comfortable and surrounded by family, and there's been a focus on comfort and peace of mind and kind of feelings of belonging and love. Today, we see more people dying in hospitals. A lot of this comes from doctors wanting their patients to be in an environment where they have the best tools possible to help them. But this means that things are really highly regulated. There are rules determining what type of food patients can have and the number of visitors and so on. Hospice is an alternative to standard hospital care for terminally ill individuals who have less than 6 months to live. So here, the goal is to get the patient comfortable and pain-free in kind of a dignified and peaceful environment. This is sometimes also called palliative care. And again, the goal is to control pain and physical symptoms, not necessarily to save life, because often it's known that the patient is going to pass away. Hospice programs often focus on treating all members of the family kind of in the circle of care, so taking care of the family as well as the patient and promoting a good death. So a death that's free from avoidable distress and suffering for patients and families, that matches the individual and family's wishes as well as meets kind of cultural and ethical standards. Another thing to think about in older adults is suicide, and actually suicide does occur and occurs not relatively frequently, but it does actually, there's a little uptake in suicide in older adults. But a specific type of suicide that we need to think about is euthanasia or physician-assisted suicide. So euthanasia or mercy killing is sometimes, it literally translates to good death. And there's two different types. There's active euthanasia, which is a deliberate or intentional act, like injecting a drug to hasten the death of an individual with a terminal illness or disability or some kind of painful disease. In contrast, passive euthanasia is death induced by failure to act or withdrawal, or the withdrawal of life-sustaining medication and machines. Euthanasia is against the Hippocratic oath that physicians take and is generally frowned upon. But some other alternatives are the fact that if the decision to withhold a treatment that would delay death puts kind of a moral responsibility, something like a DNR puts a moral responsibility on the person themselves and is much easier for the family. So if the patient themselves says, I do not want you to save my life in these circumstances, I would prefer to die, it means that it's not the family's decision, it's the patient's. Physician-assisted suicide is when the physician ends the lives of their patients at their request. So euthanasia is not necessarily at the onus of the patient. Physician-assisted suicide is legal in some countries. Often the conditions are that the patient needs to be, their suffering needs to be irremediable and unbearable. A second physician has to agree, and the patient has to be of sound mind and has to be able to express their opinions. In Oregon, a few years ago, the Death with Dignity Act was passed, and so this is what the video that you watched for this week, How to Die in Oregon, is about. Generally, very few patients take advantage of this and use this, and often this is basically physicians prescribe medication that the patient administers themselves. And what we find is there are more prescriptions written than actually filled or used. But patients do this because they feel like they have a loss of autonomy and a decreased ability to do things that would make them happy in life and kind of a loss of dignity. These are kind of ethically, and there are a lot of ethical and moral concerns with this. And so this is a pretty controversial topic, and so we'll talk about this in our discussion forum. In terms of our cultural attitudes towards death as society, we generally gloss over death. We use euphemistic phrases. We often isolate older adults who might remind us of death. And our medical community really emphasizes prolonging life, and even things like the fact that people often try to cover up emotions at funerals help with this kind of avoidance or denial. Generally, we find death uncomfortable, we don't want to talk about it, and we focus on kind of helping people get over it. But in terms of how we actually deal with death, the Kubler-Ross's theory is one of the most widely cited views on how people deal with death and loss. So this can be the death of a loved one, or if an individual has a terminal illness and knows they'll be facing their own death, they can also go through this for themselves as well. So the denial and disbelief phase is kind of the perspective that, oh, this is impossible, it must be a mistake. Anger comes with resentment, rage, envy, why me, anger at physicians or people who symbolize life and energy that the individual does not have. Bargaining comes with hopes that death will be postponed or delayed, kind of promise to reform their life by dedicating themselves to God or things like that. If I do this, then I won't get sick or I won't die. Depression is kind of accepting the certainty with the growing severity of symptoms, maybe mourning the loss of themselves or experiences, refusing visitors, and sometimes spending time crying and grieving. So a lot of kind of typical symptoms of depression, but focused on this loss. And then finally, acceptance, which comes with a sense of peace, acceptance of fate, and kind of a lack of necessarily these negative feelings, and physical pain. So we used to kind of think that people went through this in an invariant sequence, and you only are in one phase at once. Now we know that it's not always in this order. Sometimes the phases overlap. So for example, this figure does a nice job of kind of showing that it's not entirely stages. In particular, we can see that acceptance kind of continues, gradually increasing over the time from loss, whereas the other phases increase and then decrease in turn. And so other things associated with the grieving process, in the first few days, people report numbness, shock, disbelief, weeping, agitation, disorientation, those kind of signs of distress. From 2 to 4 weeks after death, we see more kind of intense longing. So imagining the presence of their loved one, or desiring to see that person. And you see kind of a range of emotions, but also physical symptoms like aches and pains are not uncommon. Next is a realistic appraisal. So eventually people get to the point where they start thinking about, okay, realistically, what is my evaluation of what this loss means? And this can elicit different reactions in survivors depending on what the loss will mean to them. And then normally within a year, people essentially recover. They resume their normal activities and social relationships. They identify with the deceased, but it becomes kind of part of their story rather than preventing them from engaging in daily life. So the video that we'll watch for this week in our discussion forum really focuses on, kind of helps us delve into some of these issues with death a little